All right, hello everyone. So this lecture will be recorded for you all to view at your earliest convenience. This lecture is dedicated to drug-induced hematologic disorders and thrombocytopenia, as you can see by the title. So I will get right into it. Okay. So the learning objectives for this lecture will be to highlight or to identify the highlighted causative medications that are associated with the discussed hematologic disorders. We'll also go into the management options of the hematologic disorders, describe the pathogenesis of HIT or heparin-induced thrombocytopenia. We'll go through a patient case, and my apologies, that's supposed to say case, be able to apply the 4T scoring system for hit probability, know the alternative anticoagulants use in the acute treatment of hit, identify and describe surveillance options for reporting potential drug-induced adverse effects, and describe the pathophysiology of immune-mediated thrombocytopenia or ITP. We'll also go through the lab findings that are associated with chronic ITP, and we'll compare and contrast the treatment options for ITP with regards to the efficacy, mechanism, as well as the safety and associated adverse effects. So if I was able to deliver this lecture to you in person, I would have posed this active learning question to you all. But for the purposes of this recording, the first question, so which of the following is not part of a cell line? So you all should be able to identify adipocytes as the correct answer. That's because adipocytes are these fat cells, and we never discuss those as it ties to the content in hematopoiesis. So you'll note that a lot of the content that we covered in hematopoiesis and just the overview that was provided during that lecture is going to come back more in detail during this lecture. So we'll get right into it. So just to reiterate, adipocytes is the correct answer here as it's not part of the cell line, whereas everything else is. So platelets, lymphocytes, erythrocytes, which are red blood cells, and then basophils we've talked about. So all of the rest are. Okay, so we'll go into drug-induced aplastic anemia, and some of you may remember aplastic anemia is essentially it's a decline or it's an adverse effect to all three um, types of like everything that composes blood, so the white blood cells, red blood cells, as well as the platelets. So everything is being affected in the case of aplastic anemia. Um, and another way of describing that is called pancytopenia, where there's, essentially a decline in all three components of the blood. Um, and there's no evidence of, without evidence of increased peripheral blood cell destruction, which is replaced by fat cells. This could be inherited or acquired. And acquired is important, again, thinking as a pharmacist, because we want to be able to identify medications that a patient is on that could be leading to this picture of aplastic anemia. So the way that this is diagnosed is that there are two of the following criteria, that being a decline in white blood cells, so that being 3,500 or less, a platelet drop of 55,000 or less, and then a hemoglobin drop of 10 or less, with a reticulocyte count, which is below, either at 30,000 or below. Um, and usually a bone marrow aspirate and biopsy is required to exclude other causes of pancytopenia. So the key diagnostic measure is doing a biopsy. And it's further classified as moderate severe or very severe, depending on the labs. So associated medications, and again, this is important. The ones that are in red are ones that I've specifically seen in my clinical practice that have been, associated to cause this aplastic anemia picture or this pancytopenia picture. But other things could be drugs as, the common ones that we see, which can be like NSAIDs, thiazides, furosemide, which are commonly used for cardiovascular disorders, propylthiouracil, which is used for hyperthyroidism, and then amlodipine, carvedilol, lisinopril, again, all part of the cardiovascular disorder system. So those are, things that are less commonly seen, but there have been some, there has been some evidence to indicate that they can potentially lead to this picture. So just some meds to be aware of. But again, for the purposes of your exam, I will be sure to distribute a guide that helps to direct your studying. But I would recommend paying attention to or trying to remember the medications that are here in red. So phenytoin, which is an anticonvulsant medication, basically help to treat seizures, seizure disorders. And then there's carbamazepine. So same concept. Cytotoxic chemotherapy is also something that could lead to that. So important to keep these in mind. So as far as treatment goes, obviously the first step is to discontinue the offending agent, should there be an offending agent. And then if there is a need for a transfusion, as in blood transfusion, that may have a role. After that, there may be a role for antibiotics to help prevent the onset of an infection. That is applicable if the neutrophil count is below 500. And some of you may remember, hopefully you remember that that is the subset under neutropenia that is known as agranulocytosis. So that's how you could, identify that further. And then beyond that, there could be the role for stem cell transplant, as well as immunosuppressive therapy. So these are the different components that are implemented for management of aplastic anemia. And then the decision for the stem cell transplant versus medical management depends on patient-specific factors. So just varies. And it's important to get to a diagnosis and immediately start treating because of the high mortality rate. So these patients are extremely they have a very poor prognosis, and what that means is their life expectancy isn't expected, to be as promising, or they could the chances of it being fatal for them is very high. So they should get treated as soon as possible. Okay, so these are some of the immunosuppressive therapy options, some of which I think there was mention of them very, very briefly, but just to kind of go through the details of each. So there's cyclosporin, there's anti-thymocyte globulin, there's eltrombopag. As you can see, the details of each are listed here for your reference. My exam doesn't necessarily go into the detail, or like what I mean by that is my exam questions don't really go into the depths of the mechanism, the dosing, or anything. This is more so just so that you're aware that these are the agents that make up the immunosuppressive therapy. And from a practical standpoint, the most common one that I've seen is cyclosporin. So you can see the details of that. And then as far as side effects are concerned, typically there's actually quite a bit of overlap of the cyclosporin side effects with corticosteroids. So there could be, a wide range of organ systems being affected, hypertension, edema, headache, an increase in triglycerides, so a little bit of like metabolic abnormalities, nausea, diarrhea, increase in serum creatinine, aka renal dysfunction. So things like that, which, could happen. And then you can see the details of the others. But again, just wanted to introduce these agents. We don't necessarily have to go into the details of how each one works and then how it's dosed or anything like that. So just as an FYI. Okay, so now going into drug-induced agranulocytosis, which I did briefly mention, and I've also given quite a bit of heads up as far as like which drug is the most common one that, is clinically seen to cause agranulocytosis, which is clozapine, which is a second generation antipsychotic, typically used for the treatment of like treatment-resistant schizophrenia, which you'll learn more about. But just to go over the background of agranulocytosis, this is a reduction in the number of granulocytes, particularly the neutrophils and the bands. So again, characterized by a count of 500 cells per millimeters cubed or less. It's a severe form of neutropenia, essentially, and this could be inherited or acquired, and could be caused by decreased production or direct cytotoxicity, which again is due to the usage of a drug. It could be because of an infection or immune mediated, and this could also be because of the usage of a certain drug. All right. And then cytotoxic chemotherapy or immunosuppressant agent triggers are expected, whereas most others are considered idiosyncratic, meaning without a clear cause or sort of like an unknown cause as to what leads to it. The typical onset is 1 to 2 months after drug initiation. And the symptoms that arise from increased infection risk are associated with the lack of uh, the white blood cell count. And as far as the specifics of the symptoms go, like the things that we see these patients with are a fever, chill, sore throat. So, the general non-specific signs and symptoms of someone having, a cold, a common cold or infection. So those are some things to expect. And then the associated agents, primarily clozapine, but you can see methimazole, propylthiouracil are also potentials. These are again treatments that are used for the management of hyperthyroidism. Sulfasalazine, this is a drug that you'll learn more about. It's one of the treatments for rheumatoid arthritis. So that's also a potential. And then you can see a whole list of other medications that could also be attributing to the development of agranulocytosis. But again, the ones that are in red are definitely more common. So then management for agranulocytosis obviously involves removal of the offending agent. And as at this point, you can probably tell that when we have a drug-induced blood disorder, the first step is always to ensure that there is nothing that is making their picture worse. So always ensure that there isn't further exacerbation happening due to something that, is concurrently there. And then the blood cell count usually returns back to normal within 2 to 4 week time frame. Restarting the drug is not recommended unless there's clinical ramifications. And what that basically means is the benefit outweighs the risk of a certain course of treatment. So, in parentheses, you can see PCNs, which is short for penicillins. So, what that means is if, say, for example, there's a patient who is being treated with a penicillin antibiotic, and they have, treatment for um, a certain period of time, but they happen to develop agranulocytosis, and the penicillin antibiotic is the most appropriate drug of choice because of the specific infection that the patient has, then it may be worth our while to closely monitor the patient, keep them on that course of treatment because that treatment will come to an end. It more so is a concern when we have drugs like, for example, the hyperthyroidism drugs like methimazole or propylthiouracil. Those are expected to be part of a patient's medication regimen for life. So it's difficult for us to think about discontinuing them, or I guess thinking about um, the implications of that, and then thinking about agranulocytosis, there is more risk involved with something that we're keeping on for an indefinite period of time. So, bottom line, thinking about the benefit outweighing the risk is um, what is compelling to keep something, to continue with something. And if that concept isn't clear, then I can certainly clarify further the next time that I'm in person to lecture, but essentially we have to just watch for whether it would be a good idea to continue whatever medication is causing the agranulocytosis or not. And the bottom line is if we are treating for a finite period of time, then it probably would be fine. But if we're thinking about treating with the medication for life, then we run into that, constant risk of leading to that blood disorder, or in this case, agranulocytosis. Um, the next step is to monitor and manage any sort of infection onset as appropriate. And then we have the options of thinking about filgrastim or sargramostim, which are these colony stimulating factor medications. They're indicated for the treatment of febrile neutropenia, which basically means that patients who develop neutropenia and have, systemic signs of an infection or systemic signs of like, just having a suppressed immune system. So they have a fever. It's characterized that way. And again, neutropenia is kind of like the umbrella, and under that is what agranulocytosis is. So because of that, we could consider starting treatment with either one of these. And there's like a dedicated regimen for each of them as far as dosing goes. We don't need to get into the specifics, but these are some options that we could resort to. And then you can see the details of each. So I just kind of introduced them on the previous slide, but stands the GM CSF versus GCSF stands for granulocyte macrophage colony stimulating factor, and then filgrastim granulocyte colony stimulating factor. So they basically both work similarly. One stimulates neutrophils, dendritic cells, and macrophages, and then filgrastim that stimulates the neutrophil and dendritic cell production. Both are available via subcutaneous and IV administration, though the subcutaneous route is usually preferred. And then the pharmacology, pharmacokinetics, and toxicities vary between the two, but essentially they are similar in how they manage such patients. Okay, now moving right along to the next blood disorder, drug-induced hemolytic anemia. And we briefly spoke about this during sickle cell. So we'll talk more about that. So red blood cells, they normally survive for 120 days. And you probably learned this at some point during the series. Premature red blood cell destruction is called hemolysis or hemolysis. This occurs because of defective red blood cells or abnormal changes in the intravascular environment. So when we think about sickle cell disease, the red blood cells, they only live for about 10 to 20 days. So there's an extreme amount of defect or extreme amount of sickling that leads to such a short life. And then the drugs, they can promote both processes of that. And again, it can be inherited or acquired as are other blood disorders. The symptoms, they could vary, and it also depends on the drug and mechanism of hemolysis. So there's the general anemia, signs and symptoms that we've discussed during the anemia lecture series. So fatigue, malaise, shortness of breath, abdominal pain, red urine. As far as testing goes, so there's a Coombs test that's done to confirm hemolysis. This combines the red blood cells with a reagent. And then if you see evidence of clumping or agglutination, that signifies hemolysis. So like the breakdown of red blood cells. And so there's two mechanisms of how hemolysis occurs. There's the immune versus metabolic. Immune involves our different antibodies, so the IgG, IgM, or both. They bind to antigens on the red blood cells and initiate destruction. And this can be drug dependent or independent. And then whereas metabolic, this is more oxidative. So this most often occurs in the presence of glucose 6 phosphate dehydrogenase deficiency. That's a mouthful, which is short for G6PD. And there are certain drugs that are not to be used in patients who have this deficiency. Otherwise, it would lead to the onset of hemolytic anemia. And we'll talk more about that. This can be drug dependent or independent, similar to immune. So as for associated agents, it's different for immune versus metabolic, as you can see here. For immune, the most common antibiotic that could lead to the onset of hemolytic anemia is piperacillin, which is a type of penicillin antibiotic. And then there's diclofenac, which is a type of NSAID. There's, other agents as well. And then as far as metabolic agents are concerned, we have dapsone. Another common one, which I haven't made red here, but actually recently saw it in clinical use, was primaquine, which is used for the management of um, infections that could occur as a result of a patient having HIV and not adhering to their HIV regimen. So, in that situation, they have a suppressed immune system and they run into the risk of acquiring certain infections, in which case, primaquine is an agent that may be used, and dapsone is also actually part of that category. So, again, these agents cannot be initiated until a patient is checked for G6PD deficiency. If they are deficient, then we cannot use these agents. They are contraindicated. So again, just because we run into the risk of them developing hemolytic anemia, which could lead to a series of complications. Okay, so as far as treatment goes, for each, it's obviously removal of the offending agent, and then supportive care applicable to both. For immune, we could go with management with other medications such as glucocorticoids, rituximab, IgG treatments, but the role is yet to be clearly defined in therapy, so still a little bit of lack of clarity with how exactly to manage, but there's a little bit more room as far as like other interventions go. Metabolic is solely driven by removal of the offending agent. So definitely ensuring that whatever is causing the hemolytic anemia, that be discontinued as soon as possible. And then just to clarify, supportive care means whatever management is needed to alleviate the symptoms and mitigate whatever the patient is presenting with. So if they are dehydrated, ensuring that they have adequate hydration with fluids and maintaining that. And then if they are feverish, then things like Tylenol, electrolyte repletion, things like that is what supportive care entails. Okay, on to the next. So, as you can see, we're just going through like all the different drug-induced disorders. This one is a bigger category, just as a heads up before we go into it. So when we think about drug-induced thrombocytopenia, um, my bad. Okay. Let's just making sure I didn't skip it. Yeah, okay. So thrombocytopenia, briefly introduced this during the hematopoiesis lecture. This is characterized by a platelet count of less than 100,000. I know I mentioned that essentially a platelet count that is below 150,000 is considered like below our target range or below what is considered normal. So the definition in itself is usually less than 100,000. That's when it becomes more of like a where we would want to intervene. Um, it could also be as more of like a measure to what the patient was at baseline. So if there's a greater than 50% reduction from baseline, then that could also be, indicative of thrombocytopenia. Like, for example, if a patient's baseline was 450,000 platelets, and if we're thinking a drop in that, that would be somewhere around like the 200,000s, which is within range, but because of the fact that it dropped greater than 50%, we would characterize that as, this particular disorder. Drug-induced thrombocytopenia occurs in about 10 per a million cases, which excludes heparin, as in heparin is its own entity. It's often misdiagnosed as ITP. drug-induced thrombocytopenia, which is associated with more bleeding and lower platelet counts. And we'll go into ITP a little bit later in the presentation. So this is again just looking at drug-induced thrombocytopenia independent of heparin. Typically, this presents 1 to 2 weeks after a new drug is initiated, but it can present immediately upon re-exposure. And then the associated drugs or the drug classes are here for your reference. The ones that in red are again the ones that I've clinically seen to cause thrombocytopenia. But for sure, the other ones, they are associated with that risk as well. And then the management, it involves discontinuation, of course, of the offending agent and supportive care, and then consider steroids and IVIG. And you can see on the right-hand side just kind of the algorithm. So you start with, looking at the patient's platelet count. You see a new onset of that, and, a patient taking a new drug, potentially one from the list that you see on the slide here. And then you basically take a look at the different criteria, looking at the platelet count, nadir, which is basically like the lowest that the platelet count goes to. So if it's dropped below 20,000, and then you identify whether that is the case or not, and then you just kind of follow the direction of that, and then that helps for you to characterize whether this is a drug-induced thrombocytopenia case or not. And then we'll get into just kind of the specifics. But yeah, definitely discontinuation of the offending agent is always the starting point, and then we go from there. All right, so that was again just generally speaking drugs that are not heparin. Heparin-induced thrombocytopenia is kind of its own entity because this is something that does happen. The frequency with which this happens, like a true hit case, is actually very rare. So it's not that often, but it is something that even like as you get to NAPLEX preparation, the NAPLEX book goes into the details of just kind of the background of this and like what's done to manage it. So it's important for us to cover that. So this is an immune-mediated disorder that's caused by development of antibodies against platelet factor 4 and heparin complexes. And it leads to more thromboembolic complications than bleeding complications, which is ironic because heparin is a blood thinner. You'll learn more about anticoagulation, everything with me in the fall. Yes, sorry, took me a second to remember when cardio is, but I am the primary course instructor and coordinator for cardio, so anticoagulation is covered within that PT module. But anyway, just to give you a little bit of an intro, heparin is a blood thinner, and in the case of HIT, it works in the opposite way. It leads to more of like the clotting picture rather than the blood thinning picture, like blood thinning effect, that's why it's paradoxical. And the thrombosis risk exists even with alternative anticoagulant treatment. So we have two types of HIT. The first type is more mild, reversible, and it's non-immune mediated. It's within the first 2 days of therapy typically, and it occurs in about 1% of patients treated with heparin, so very, very infrequent, rare sort of a thing, and about 0.1% of patients treated with enoxaparin, which is a low molecular weight heparin. The platelet count slowly returns to baseline, and usually these patients, they don't have any symptoms, so pretty stable. And then when we think about, or when we look at type 2 HIT, this platelet count declines 5 to 10 days after the start of heparin therapy. It could be within hours if they have received heparin before. So it just kind of varies with the platelet count dropping and like just the timing of that. And then this image, it illustrates the pathogenesis of HIT. The key thing that I'd like for you to focus on is actually in the star. So you can see here, I hope my cursor is showing up in this recording, but essentially it starts right here. So the platelet alpha granules release PF4. This essentially binds to basically PF4 and heparin bind, forming a complex bound by IgG. And then there's these FC receptors bind the hit antibody. And then the effects of that are, aggregation, platelet activation, procoagulant microparticles. Um, and then, you just sort of get this like thrombotic picture. And again, thrombosis and thrombin, thrombocytopenia, all these things are in simple terms basically leading to this like clot-like picture, which is not the effect that we want because again, we use heparin in cases where there is clotting. So what we want is the heparin to work as a blood thinner to make it so that it's an anti-clot effect. But in the situation of HIT, we are pretty much making the problem worse. The clotting gets even worse because there is this complex that's being formed that's leading to this sort of immune reaction. So it's doing the opposite of what we want it to do. And then we have the 4T scoring system for HIT. So you can see here there's the 4Ts, which basically predicts the probability of like what are the chances that this is a true HIT case. So you can see like just the different points that are that correspond to each criteria. So when we think about the thrombocytopenia, like the platelet count fall, the extent of which that happens, the timing of the platelet count fall, thrombosis or other sequelae, and then other causes for thrombocytopenia. And you can see what the scores would mean. So if you have a score between 1 to 3, that's probably low probability. A score of 4 to 5 is somewhere in the middle, and then score of 6 to 8 indicates probably like a high chance that this is a true hit case. So that's how that looks like. And then this figure, it helps to just kind of guide your diagnosis and then also just kind of the how you ultimately confirm the presence of HIT. So the key thing to note here is that the serotonin release assay is what pretty much tells us the final yes or no as to whether it is a true hit case or not. Um, Before that, we do this like something that is called the ELISA test, which is like this immunoassay result. So either that comes out to be positive or negative. But the serotonin release assay is essentially the true test or the true diagnostic measure of confirming the presence of HIT. And then yeah, this figure pretty much lays out how the 4T scores are interpreted and just kind of what steps follow thereafter. Okay, so treatment of HIT, obviously, like every other drug-induced blood disorder, you always want to remove the offending agent, aka take off, any heparin product, even if it's like a low molecular weight heparin or enoxaparin. Initiate an alternative anticoagulation agent immediately, and we'll get to the specifics of those. Um, and then those are to be dosed at therapeutic doses, not prophylactic doses. So we are to still treat the indication normally. It's not meant as like a preventative, but the way that we would have treated it with the heparin product. So some options are direct thrombin inhibitors. So that includes argatroban and bivalirudin. There's also factor 10A inhibitors. And then the other class of medications are DOACs, which are direct oral anticoagulants. These aren't currently approved, but they're being increasingly used. There's just not enough robust data to support their use quite yet, but I do think that with additional studies, like they will be a solid alternative. And then there's also symptomatic treatment, which is, in line with like supportive care. So ensuring that whatever the patient is experiencing, we try to mitigate that. All right, so going into the details of argatroban, this is a direct thrombin inhibitor. You can see the dosing details there, more so for your reference. This is titrated per the APTT. So this is like a lab value, and it is usually driven by nursing, actually, like um, the nursing department in the hospital usually closely titrates the drip according to what the APTT value is. And our therapeutic window for this is actually very narrow. So we have to, keep an eye on it pretty regularly, like every couple of hours to ensure that it is where we want it to be. As far as considerations go, like clinical considerations for use, this does have an INR prolonging effect. So when we think about certain anticoagulants that could potentially do this, warfarin is the key one to think of. I'm not sure how much you have been introduced to warfarin. I believe we will be working through a lab dedicated to warfarin use later on in this semester. But essentially, the INR is a value that we keep a close eye on whenever a patient is on warfarin. And that helps for us to ensure that the patient is within goal. If it's too high, then that means the patient is at risk for bleeding. If it's too low, then that means the patient is at risk for clotting. So those are some things that we keep an eye on. But again, relating it back to our argatroban, so INR is actually something that, like if it's dysregulated, it could be a marker of hepatic dysfunction. So, just abnormalities with the liver, and argatroban is metabolized through the liver. So that's, something that, would make sense. It is safe for use in renal impairment, which is a really big advantage because a lot of times patients are, they have some sort of renal dysfunction or they are end stage renal disease dependent on dialysis. So for that reason, our argatroban works really well. In my clinical practice, this is the primary agent of choice whenever there's a high suspicion for HIT. So we usually resort to our argatroban. The next agent that is on the market is bavalarutin. This is also a direct thrombin inhibitor, and you can see just the dosing details. This is also titrated per the APTT, so same concept. Usually driven by the nursing department and monitored every couple of hours. We try to, well, they try to ensure that it stays within a certain value, so that the patient isn't as at risk for clotting or at risk for bleeding. And then other considerations, so it has an off-label use except for HIT related to percutaneous coronary intervention or PCI. This is something that is an intervention in patients who have a heart attack, essentially, or what we call acute coronary syndromes. So more to come with that, but we don't need to go into the specifics of that at this time. This has a short duration of effect, so that can be a little bit of a barrier. And this does require renal dosage adjustment. So a lot of times, patients aren't candidates for this. I would say for the purposes of this lecture, just kind of know that argatroban and bavalarutin are, direct thrombin inhibitors that are possible options for HIT management. We also have fondaparinux, which is a factor 10A inhibitor. And then you can see the dosing is specific to the weight of the patient. It's been, considered controversial whether it can induce HIT antibodies, but it's generally considered safe and effective. This also requires renal dosage adjustment. And so that could be a little bit of a challenge. It may be favored in pregnancy, so that's an advantage. Because generally, when we think about heparin products, enoxaparin and heparin, enoxaparin in particular is actually pregnancy category B. So it is considered probably the safest anticoagulant in the situation that a patient develops HIT. In response to enoxaparin therapy, fondaparinux is probably the best alternative that is there to help, manage whatever coagulation that may be happening, or just to prevent the formation of additional clotting. And then we have our oral anticoagulant options. So DOACs and then vitamin K antagonists. Briefly talked about warfarin already, but to go into the DOAC category, so we have direct factor 10A inhibitors, which includes rivaroxaban and apixaban. And then we have our oral direct thrombin inhibitor. We looked at argatroban and bivalirudin, which are also direct thrombin inhibitors, but dabigatran is oral. So that's a key difference. There's potential long-term, this may be a potential long-term option given their increased use in a lot of institutions. Most of the data that is available is with actually rivaroxaban, but still not highly favored because the data isn't too robust. New and upcoming, area of research, I suppose. And then vitamin K antagonists, we have warfarin. This is an appropriate and acute hit because it could lead to skin necrosis and gangrene, and it could worsen the thrombosis, so not ideal whatsoever. And as far as like anticoagulation treatment goes, I mean, it would be ideal for long-term management, but it must be transitioned to from a non-heparin anticoagulant when the platelets are at least 150,000. So when they've normalized in their count. All right. Now to go into immune thrombocytopenia or ITP, also known as idiopathic thrombocytopenia purpura. So big names. All right, so the background of ITP, this is a disorder where there's an immune-mediated destruction of platelets and inhibition of platelet release from the megakaryocytes. Uh, So there's an autoantibody that forms against this structural platelet antigen. It's termed primary if it's isolated without other causes, and secondary if there are underlying causes linked to it. It's characterized as newly diagnosed, or persistent, or chronic. So these are the three main categories, and this is based on, just kind of the timing of when they were diagnosed, as you can see, less than 3 months, between 3 to 12 months, or greater than 12 months. And it's often acute in kids and chronic in adults. So, as far as what we want to aim for treatment, it's to reduce the risk of clinically important bleeding, not to normalize the platelet count. So, a little counterintuitive. We try to ensure that the patient isn't at risk to bleed, first and foremost. The mild thrombocytopenia cases, they don't typically warrant therapy in the absence of bleeding. So we just kind of monitor and observe. Treatment is generally utilized in patients with a new diagnosis of ITP and or who have a platelet count of less than 30,000. Those who have at least a platelet count of 30,000 but are at increased risk of bleeding may also be considered. And then there's an increased risk in patients with prior bleeding, platelet count of less than 10,000, and if they're older than 60 years of age. And then the choice of therapy, it depends on the severity of the bleeding as well as the bleeding risk. Some non-pharmacologic options or considerations would be to, just go about daily precautions with trying to minimize the risk of bleeding, avoidance of extreme sports, avoidance of antiplatelet medications, and then also minimizing any sort of alcohol intake. And just to clarify, antiplatelet medications include things like, something that may be considered like benign, like baby aspirin, clopidogrel, or Plavix. These are, some examples. All right, so then treatment of ITP. So there's two groups. There's patients without significant bleeding symptoms, but they have severe thrombocytopenia, or they have signs of impending bleeding. And then there's the category of patients with severe ITP and or symptoms of bleeding. So one that's considered, I guess, more on the mild to moderate side, and then one that's considered more on the severe side. So the one above is more like mild to moderate. So we go about weight-based dosing with prednisone typically. We may opt for IVIG, which is IV gamma globulin, which is given over 1 to 5 days. And there's, the possibility of using this RH factor, RH immune globulin product, again, just to regulate these patients, ensuring that they're not at risk for bleeding further. And then there's the patients with severe ITP and or symptoms of bleeding. So for them, we typically opt for a high-dose glucocorticoid plus IVIG. So it's a combination of the two, not just one or the other. And then we may think about additional immunosuppressants such as rituximab. There's also the thrombopoietin receptor agonists, which could be used in chronic disease. In refractory cases, they may require removal of the spleen. So that's, also a potential option. Glucocorticoids work by decreasing the antibody production and platelet clearance by macrophages. And then you can see, again, like a different variation of the weight-based dosing. On the previous slide, you saw prednisone 1 milligram per kilogram. So somewhere between that is probably like between this range of zero point 0.5 to 2 is 1. So, but it could truly be, a little bit lower or on the higher end until we see an improvement. And then we taper, or we go with a high dose steroid, which is dexamethasone, which is the most potent type of steroid, which could be given over a 4-day course, typically like 10 milligrams every day for 4 days, which amounts to 40 milligrams during that course. And then you can see, a number of side effects that could affect so many different organ systems, the eyes, cardiovascular system, metabolically, like thinking about, endocrine, like hyperglycemia, osteoporosis, mental status, and mental health. Most patients, they respond within 1 to 2 weeks of therapy, and generally undergo a trial for 3 months before transitioning to second line therapy. So we really ensure that patients are adequately treated with the steroid course before thinking about other methods. And then IVIG, so just to give a bit more background on this, this is a blood product of pooled human IgG antibodies. It's been used for the management of ITP since the 80s, so very tried and tested and considered to be very effective, and it's considered to be safe as well. Infusion reactions are common, such as headaches, chills, vomiting, hypotension. And rare but serious adverse effects may include anaphylaxis, hemolytic anemia, kidney dysfunction, and thrombosis. Works, immediately upon infusion, and it may be preferred in acute bleeds, which is why they are considered part of like the combination with steroid treatment. So they ought to be given together rather than it be like a stepwise approach. Usually given as 1 gram per kilogram bolus or 1 to 2 grams per kilogram total over 4 to 5 days. And we have certain concentrations, so the 10% IVIG products are preferred with this particular indication. Remission only lasts for about 3 to 4 weeks, so repeat administration is common of the IVIG. All right, so refractory ITP, which basically means like treatment-resistant ITP, as in we've tried our first line, we tried our second line, we've exhausted the use of glucocorticoids or corticosteroids, used interchangeably, and we've done our IVIG. What can we do thereafter if there's still no response to treatment? So we have the option for rituximab, and this is basically an agent that is an antibody against CD20 on B cells, which leads to B cell depletion and decreased antibody production. You can see the dosing, it's on a weekly basis, and for 4 doses, it's infused via IV, and there's often relapses. So what that means is there's often this sort of failure to treatment or just like not necessarily responding to treatment right away. So it does mean, recurrent use of this particular line of therapy. It could lead to significant toxicities, some of which have been highlighted here. So infusion reactions, infection, hepatitis B reactivation, Could also lead to dermatologic reactions. So not an easy agent to use. Plus, it's very expensive. So it does present quite a few challenges. And then we have our thrombopoietin receptor agonist, TPO-RAs, one of which I did introduce at the beginning as like immunosuppressive therapy, which was Ultramapag. So of this class, there's like these three that are available. And again, these are just to introduce you to them and just to give you a sense of, just the class that they belong to. So you can see the details of each of them. There's, the option for subcutaneous injection, and then there's also the option for oral medications. And then you can see the details of each, like just as far as uh, the administration goes. So Ultramapag requires fasting state for absorption and has a black box warning for hepatotoxicity. Avatrombopag, this is also one of the oral medications, doesn't have any food restrictions. So just kind of depends on patient-specific factors as to which one we might try. Okay, and then this is just to give you a sense of how TPO-RAs are considered an option. So most of the circulating TPO is cleared by platelets. There's unbound or free TPO that stimulates proliferation and differentiation of megakaryocytes. And then when docked at the TPO receptor, this will act to amplify the production of the precursor megakaryocytes and platelets. Um, Free TPO normally has an inverse relationship with the number of megakaryocytes and platelets, but in ITP, the platelets are still being made at a near normal rate, but they're being cleared at an increased rate. Despite their shortened survival, the platelets still bind and clear the TPO at a normal rate, and TPO levels do not significantly rise. So then when we use these products, which are like these recombinant receptor agonists, they mimic endogenous thrombopoietin or TPO, and they're used to stimulate the production of megakaryocytes and platelets. So just an interesting background of kind of like what they do or why we resort to such a line of treatment. And there's a really good clinical response rate. So, although we resort to them in more refractory cases, they are considered quite a solid drug as far as what we're trying to achieve. And then you can see just they're pretty well tolerated, may lead to rebound thrombocytopenia when stopped. So that could be a bit of a challenge. And then rare but serious toxicities include thrombosis, as well as bone marrow fibrosis, which could increase the risk of hematologic malignancy. So that's a bit of a challenge as well, but rare. And then we also have this agent called fostamatinib. This was approved in 2018 for adult patients with chronic ITP who have an insufficient response to previous treatment. Has a little bit of a unique mechanism. And you can see the dosing, it's orally dosed, and there's a response rate of about 43% versus placebo, which is 14%. So nothing, like not insanely good, but at the same time, just another novel way of potentially managing ITP. The most common side effects you can see are, like GI, potentially increase in blood pressure. Okay, and then the last option, my apologies, the last option is splenectomy, as in removal of the spleen. So the spleen normally removes targeted platelets from the bloodstream and is also a site for antibody production. So that's why it could be considered a potential intervention. This will help to reduce the platelet destruction and antibody formation. However, since the liver and bloodstream also remove circulating platelets, splenectomy it's not always the most successful decision. And about 65% of patients remain in clinical remission for about 5 to 10 years. Ideally, wait 12 months before considering a splenectomy. Optimize platelet counts preoperatively, prepare for appropriate vaccinations and post-surgical care. Um, Splenectomy results in a lifelong increased risk of sepsis from infection by encapsulated bacteria. It's also associated with increased risk of thrombosis, death from cardiovascular disease, and then pulmonary hypertension. So, splenectomy comes with a lot of implications, and risk of complications, especially just with like having an extremely suppressed immune system. So, just chances of patients acquiring an infection easily. All right. And then supportive care. This is kind of just like the order in which we go about the different interventions that are tied to that in life-threatening bleeding. So oxygen support, IV fluids, blood products, giving an antifibrinolytic treatment, and then withdrawal of the offending medications, of course. Okay, and then surveillance, which is a category of its own. So we have something called the Naranjo scale. This is a common tool that's used to rate the likelihood of causality of adverse drug reaction investigations. This provides a series of scored questions that help to determine the likelihood of an ADR, and as to whether it was caused by a certain medication. So again, like it's scoring, and then the higher the score, the more likely it is that there was a particular medication that led to a certain reaction. And, by a score of 9 or more, that's considered definite, 5 to 8 probable. And then, the lower it is, the less likelihood of that being the case. And then there's also the FDA MedWatch. This is the FDA's Safety Information and Adverse Event Reporting Program since 93. It's used to report adverse or sentinel events, and, post-marketing surveillance. So, in summary, drug-induced hematologic disorders can affect any cell line, as we saw, a variety of drug-induced blood disorders. And then also, although rare, sorry, I wrote rate, but although rare, they are a dangerous and under-recognized cause of morbidity and mortality. The symptoms and timing of presentation depend on the cell line that is affected, and prompt recognition and removal of the offending agent are essential. Re-challenging a patient with an agent is generally not recommended. Again, it goes back to the concept of benefit versus risk. So that particular scenario with like penicillins, like when we know that it's going to be for a finite period of time, then it may be appropriate. But again, with very close, vigilant monitoring, if the monitoring is not practical for us to do, then it may not be worth our while. Which is considered the most severe drug-induced hematologic disease. So again, I will just answer this for us. That would be aplastic anemia. I'm so sorry. Just okay. It would be aplastic anemia, given the fact that all three blood cell components would be affected or would be in a state of decline. White blood cells, red blood cells, as well as platelets. Agranulocytosis affects the white blood cell line, particularly of neutropenia. And then there's hemolytic anemia, which is mainly of the red blood cells. And we see a decline in hemoglobin. So, that's just those specific subsets, whereas aplastic anemia affects it all. A patient with recent hit presents with deep vein thrombosis in the left lower extremity. Initial outpatient treatment should include enoxaparin, argatroban, or fondaparinux. So in this case, we are thinking outpatient treatment. So we can't think about argatroban, unfortunately. That would be the treatment of choice if this patient was hospitalized because, we have this whole protocol, keep a close eye on the APTT value. That would be what we would do in a normal situation. But given the fact that we want the patient to be discharged and continue treatment at home, fondaparinux would be appropriate to go with. And it would be the subcutaneous injection, which the patient can self-administer. So that would be, that would be what we would go with. The one consideration with fondaparinux is it does have to be renally adjusted. So we just have to see what this patient's renal function might be like. So that's how we would go about that. And then lastly, when evaluating drugs as a possible cause of drug-induced hematologic disease, clinicians should use which approach? Employ an ADR probability scale, expect a definite diagnosis, and rely on laboratory data for confirmation. So we should certainly employ an ADR probability scale. Um, so yeah, out of the choices that we have here, that one is probably the most appropriate. So yeah, that brings us to the end of this lecture. In case you have any questions, I'm always available to help and address them. And again, I will be sure to provide a guide to ensure that you're adequately prepared for the exam and so that you focus on the right things that were delivered during this lecture. So thank you all.